एक बार चेक कर लेना. So welcome everyone to this session. This is the Unacademy NEET PG Let's Crack NEET PG YouTube session, and today we would be discussing about the MCQs that can be asked in the retina. So this session would be very useful for all the students who are the NEET PG aspirants, also for the Ionized CT and the FMG course. So what I would be doing is I would be just posting the questions, and then I would tell you how to basically answer the questions. So in this 2-hour session, we would be dealing with all the important topics that can be asked in the field of retina and uvea. If you have any doubts in any of the questions, you can just ask me in the comment section. So should I start the session? Am I audible? Okay, fair enough. Okay. So our first question would be, we have to put the layers of retina in order from vitreous to the choroid. So our options are outer plexiform layer, inner nuclear layer, retinal pigment epithelium, and photoreceptors. So try to answer first, and then I would post the explanation of this question. Okay, so Danish says A. Perfect. So the answer here is basically that if we go from the vitreous to the choroid, the layer which is in touch with the vitreous humor is the internal limiting membrane, and the layer which is in touch with the choroid is the retinal pigment epithelium. Okay, all the layers are between the internal limiting membrane and the retinal pigment epithelium. Another classification that we do is that the layers which are basically towards the internal limiting membrane, or the layers which are towards your vitreous, that are called inner layers of the retina, and the layers which are towards your retinal pigment epithelium or towards your choroid, they are basically called the outer layers. Okay, so let's do one by one all of these questions. I have some issues with my take note. Just give me a minute. Yes, okay. So it's working now. So if you can see in this picture, the layer which is in touch with the choroid is the retinal pigment epithelium. This is called the outer layer. Okay. Then after the retinal pigment epithelium, we have the layer of the rods and cones. Okay. We have the layer of rods and cones. They are called photoreceptors. Then we have the external limiting membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer. Now if you can see these two layers, okay, the pycnotic nuclei you can appreciate here. The one which is towards your RPE, I call it outer nuclear layer, and the one towards the ILM, they are called the inner nuclear layer. Okay, Then we have the inner plexiform layer, the ganglion cell layer, nerve fiber layer, and finally the layer which is in touch with the internal limiting membrane, that is basically called the ILM. Okay, chalo. Let's move to our next question. The next question is, which of the following is not correct regarding the vitreous humor? Try to answer as fast as we can so that we can cover more of the questions. So your options are: vitreous degeneration occurs with age. Option B is have higher amount of ascorbate than in plasma, helps in maintaining intraocular pressure, has viscosity lower than that of the aqueous humor. So very good. The answer here is D. So remember, in the vitreous humor, the viscosity of the vitreous humor, it is more than that of aqueous humor. It is more jelly-like liquid as compared to the aqueous humor. Okay, so option D, this is wrong. And let's see all other options. Vitreous degeneration occurs with age. This is definitely a correct option. Have higher amount of ascorbate than in plasma. That is also correct. And helps in maintaining the intraocular pressure. That is also correct. Remember, both the vitreous humor as well as the aqueous humor, they both basically constitute the intraocular pressure. Remember, the aqueous humor have more dynamics as compared to the vitreous humor. So whenever we use the drugs, most of the drugs are basically acting on either the outflow of the aqueous humor or basically the production of aqueous humor. The drugs which are basically acting on the vitreous humor are the hyperosmotics. What are the hyperosmotics? Like your syrup glycerol, like your IV mannitol. So these are the drugs which are basically acting on the volume of the vitreous humor. They basically contract the volume of vitreous humor, and that's how they can basically cause the decrease of the pressure. So before I go with the next question, I would be just telling you the features of iconic subscription. So in the iconic subscription, you have the added advantage of the plus class as well as with the prep ladder. Okay, so you would be having the live classes, weekly test, the unlimited access to the video lectures and the structured courses as well. In the prep ladder, you would be having the study planners, study material, expert guidelines, test and analysis, as well as the personal guidance. So this is the advantage of going with the iconic subscription, which has the advantage of the plus as well as the prep ladder. Okay, let's come back to our next question. Our next question is not true regarding the interphotoreceptor matrix. So interphotoreceptor matrix is between the rods and cones. Okay, so your options are: space between the photoreceptor matrix and the RP, contains protoglycans and the glycosaminoglycans, it has hyaluronic acid receptor CD44, and D, that its function is visual cycle. So very good. The answer here is, as Danish have told us, the answer here is function is visual cycle. Now this is not the function of the interphotoreceptor matrix. This is the function of the retinal pigment epithelium. Okay, the interphotoreceptor matrix, they basically act as a immunological role. They basically make the rods and cones together in a matrix, and they also basically protect the retina from the any changes in the blood or any infection in the vitreous cavity. Okay, so it is the visual cycle is not the role of the interphotoreceptor matrix. Okay, then we have the next question. Stiles-Crawford effect is described by which of the following? Your options are: all the colors are seen grey on dark light, transmission of visual impulse to the brain, harmonious image formation by brain from corresponding points of retina, light entering the eye near the edge of the pupil produces a different photoreceptor response compared to the light entering near the center of pupil. So very good, the answer here is D. Now remember, all the colors are seen grey on the dark light. This is called Purkinje effect. Okay, do not confuse it with the Purkinje images. Purkinje images are the images of the reflection that we get from the transparent surfaces like the anterior and the posterior surface of cornea, as well as anterior and posterior surface of the lens. The Stiles-Crawford effect, what it actually means is, let's say you have a patient. and what you are doing is you are basically making the light enter to the retina from the center of the pupil, and the other light is basically entering towards the edge of the pupil. So they have two different lights, one basically entering from the center of the pupil and other from the edge of pupil. Now this light, the red one, which is basically entering from the center of pupil, it would basically put a response from the photoreceptors which is different from the one which is produced from the light which has gone through the edges of the pupil. Okay, so यहाँ पे response ज़्यादा आएगा as compared to यहाँ. This is called Stiles-Crawford effect. Is it clear, Dr. Danish, Dr. Manish? Okay, chalo. This is called Stiles-Crawford effect. Okay, so let's move to our next question. A patient presented with the giant retinal tear, excessive proliferative vitreoretinopathy, thinning of the retina. What would be the best line of management for the patient? Your options are scleral buckling, pneumatic retinopexy, wait and watch, pars plana vitrectomy with oil insertion in the vitreous cavity. Try to answer. So whenever we have a giant retinal tear, what is the meaning of giant retinal tear? This is my retina. If we have basically got a very large retinal tear which is extending in whole of the quadrant, this is called giant retinal tear. Now the problem with the giant retinal tear is its edges or its margins, they roll on towards itself. Now how can you understand this? So let's say this is the retina. Okay, this is the retina and it has detached. There is a tear in the superior part and it crumbles on its own. Okay, it crumbles on its own. This is the problem whenever we have a giant retinal tear. Are you getting my point, Dr. Danish? Now in any of the cases where there is a giant retinal tear, there is a proliferative vitreoretinopathy or there is a thinning of retina, what we have to do is we have to basically go for the vitrectomy, and after removing the whole of the vitreous, we put a silicone oil inside the vitreous cavity, because जब तक silicone oil नहीं डालेंगे ये वापस अपनी जगह पे नहीं आएगा. ओके, ये इतना क्रम्बल कर चुका है. It would not go back with just pneumatic retinopexy or scleral buckling. Is it clear, everyone? The meaning of the proliferative vitreoretinopathy and giant retinal tear. So in any case of the PVR and the giant retinal tear, we would go for the pars plana vitrectomy with oil insertion in the vitreous cavity. Okay, the answer here should be D. Chalo, let's move to our next question. So identify this picture. So this is a fundus photo that we have given. In this fundus photo, you can see the optic nerve, and around the optic nerve, you can see some blood vessels. And here elsewhere in the retina also, you are seeing some front type new blood vessels which are going from the arcade of the retinal blood vessel. So my question is, what is your diagnosis here? Proliferative diabetic retinopathy, non-proliferative diabetic retinopathy, hypertensive retinopathy, or glaucoma? So as Danish have told us, the answer here is proliferative diabetic retinopathy. So one thing very important here is that whenever you see the neovascularization, anywhere, it can be in the disc. If it is in the disc, I call it neovascularization of disc. It may be elsewhere in the retina, that is called neovascularization elsewhere. This means the patient is having a proliferative diabetic retinopathy. Now remember, a proliferative diabetic retinopathy would have all the features that would be seen in non-proliferative diabetic retinopathy as well. So proliferative diabetic retinopathy में NPDR के भी features होंगे और PDR के भी features होंगे, दोनों ही features होंगे. ओके, सो इससे कंफ्यूज मत होना कि यहाँ पर आप देख रहे हो कि कुछ हेमरेजेस पड़े हुए हैं या कुछ एक्जुडेट्स पड़े हुए हैं जिसकी वजह से आप इसको NPDR करो. रिमेंबर, NPDR में कभी भी नई वेसल्स नहीं दिखाई देंगी. ऑल द वेसल्स दैट वुड बी सीन in the NPDR would be the normal retinal vessels. New vessels are not seen here. Okay, Chalo, let's move to our next question. What is the diagnosis here? In this picture, what you are seeing is some hard exudates are near the macula. You are seeing some deep-seated hemorrhages around the retina as well. Okay, this is a patient who is suffering from very good. So this is a non-proliferative diabetic retinopathy. As I explained you earlier, whenever you are having hard exudates, microaneurysms, dot blot hemorrhages or superficial hemorrhages, they are seen more commonly or they are seen in the NPDR. And this patient, because he is having some hard exudates around the macula as well, so this is called clinically significant macular edema. Clinically significant macular edema. Okay, chalo, let's move to our next question. So next question is a ionized CT pattern question. So in this question we have the disease in one column and the signs corresponding to them in the other column. You have to match them with the following. So very good, Yash. The answer here is C. Okay, chalo, let's move to all the options one by one. So first is Coats disease. So what is there in the Coats disease? Coats disease is a disease, it's a type of vasculitis and it is seen in first decade of the life. And what happens is a patient would present with the leukocoria, a pink leukocoria, and these patients, they have special vessels around the optic nerve head. These are called telangiectasias. So in Coats disease, we see telangiectasias. Can you tell me pathognomic feature of CRAO, a specific spot which is seen in the CRAO, which is pathognomic of its appearance? So we have a cherry red spot. Okay, that is there, which is seen in CRAO. In Eales disease, what we see is, we see the vitreous hemorrhage. Okay, the patient may be having a recurrent vitreous hemorrhage. What can be seen in bacterial endocarditis? In bacterial endocarditis, what we can see is the specific spots which are called Roth spots. In the CMV retinitis, we see a specific quadrant or specific area of the retina which has the necrosis, which have the hemorrhages, which have the exudates. A specific appearance is basically called for CMV retinitis. Can you tell me what is the name of that appearance? That is called pizza pie appearance. Okay, that is called a pizza pie appearance. Then we have a CRVO. In CRVO, we have hemorrhages all around. Yes, it is called a cheese, the crab cheese appearance with tomato ketchup also. Then we have a CRVO. In CRVO, we have a hemorrhages which are all around the retina. We call it tomato splash appearance. Not tomato ketchup, it is called tomato splash appearance. Then we have a chloroquine toxicity. We have specific pigmentation, which is hypopigmentation around the periphery and the hyperpigmentation at the center. This is an irreversible toxicity of the RPE and the ganglion cells, which, as Danish have told us, is called bull's eye maculopathy. In the hypertensive retinopathy, we have specific appearance, specific signs which are seen at the blood vessels, like your Salus sign. We have another sign which is called gun sign. Okay, we have another sign which is called bonnet sign. So these signs are specifically seen in the hypertensive retinopathy. In the best vitelliform dystrophy, we get specific features like lipofuscin deposition at the level of macula. What is that called? That is called egg yolk appearance of the macula. Okay, so these are some specific named signs which are seen in many diseases. Okay, so have you got any doubt till now? Okay, chalo, let's move to our next question. Next question is, which of the following is the anti-VEGF approved by the FDA to be used in the treatment of clinically significant macular edema? So remember, there are lots of anti-VEGFs which can be given. The one which is FDA approved, what is the name? So remember, bevacizumab is also called Avastin. The very important feature is it is not FDA approved. It is not FDA approved. Only one which is FDA approved is the ranibizumab. Okay, it is the ranibizumab which is the FDA approved. Rituximab is not used in clinically significant macular edema, and Ozurdex does not come under the category of the anti-VEGF. It comes under the category of the steroid implants. Okay, so Ozurdex is a steroid implant, but yes, it can be given in the patients of clinically significant macular edema. Okay, chalo, let's move to our next question. A 25 to 30-year-old female patient came to the IOPD with blurring of vision. On fundus evaluation, there was white spots seen over the retina near the macula. After few weeks, they resolved on its own. So see, white spots were seen near the macula. These white spots then resolved. It is a young patient. The patient, because is having the involvement of macula, she is getting a basically blurring of vision. What is your diagnosis here? So remember, a CMV retinitis. Now, even if you do not know the answer, what you can do is you can basically rule out the other options. CMV retinitis cannot be the answer here. Why the CMV retinitis cannot be the answer here? First, it would be in the peripheral retina and it would not resolve on its own. You have to give the drugs like gencyclovir in these cases. Same with the retinal detachment and same with the age-related macular degeneration. Age-related macular degeneration would not come at this age, it would come at the age of, let's say, 60 to 65. Acute posterior multifocal placoid pigment epitheliopathy. Though the name looks much difficult, the answer is very simple. So first is acute, तो एकदम से हुआ है. Posterior means in the posterior, when I told you about the retinal anatomy, I told what is the meaning of posterior. Posterior means the patient is having a optic nerve and macular involvement. Okay, so it is specifically near the posterior pole. Multifocal, so if this is around the macula, you have white spots around the macula. Multifocal. Pigment epitheliopathy, so there is a basically disturbance in the retinal pigment epithelium. So this inflammation is basically there and then it resolves. So this is basically called acute posterior multifocal placoid pigment epitheliopathy. It is a type of syndrome, or it is a type of the group of diseases which can be seen, which are called white dot syndrome. Okay, so there are a lot of white dot syndrome. Out of them, one is the acute posterior multifocal placoid pigment epitheliopathy. Is it clear, Danish? Okay, chalo, let's move to our next question. Another question which is taken from the Ionized CT exam. So question is, Irridocyclitis is seen in all of the following except, your options are SLE, rheumatoid arthritis, ankylosing spondylitis, sarcoidosis, or ulcerative colitis. Try to answer. So let's see all the options one by one. SLE. Though it is an autoimmune disease, it rarely can cause a anterior uveitis. Remember, iridocyclitis is basically the anterior uveitis. Same with the rheumatoid arthritis. Rheumatoid arthritis, which is more commonly a cause of scleritis, is less commonly a cause of the iridocyclitis. Do not confuse it with the JRA, the juvenile rheumatoid arthritis. The juvenile rheumatoid arthritis is having more features which are going towards the diagnosis of iridocyclitis. But if they have the RA as the option, it goes more towards the diagnosis of the scleritis as compared to the iridocyclitis. Ankylosing spondylitis, sarcoidosis and ulcerative colitis, the most common ocular manifestation in these cases, is anterior uveitis. Okay, so all of these three would definitely cause a uveitis, but if I have to basically choose the two least common ones which are causing the uveitis, they should be 1 and 2. So the answer here would be B. Okay, so this is how we can basically solve these questions, where they have given the multiple options and then we have to basically set the options which are the answer. These questions are similar to what were asked in the PGI few years back. So in the Ionized CT exam, we would be having a lot of questions, lot of MCQs which are on the different patterns. So before I go to the next point, I would be just telling you that the Unacademy Learning app have more than 34,000 questions there. These 34,000 questions you can practice day in and day out. There are a lot of quizzes which are going on. There are a lot of free questions which are also going on. But before you go for the final exam, the most important for you is the application that you have to make is on the basis of the number of MCQs that you do in the app. Okay, so if you have any doubt in the app, what you can do is you can just go to the Let's Crack NEET PG channel. You can go to the Let's Crack NEET PG channel and there you can just tag me. Okay, you can tag me there and ask any doubt. I put a lot of MCQs also in the Let's Crack NEET PG channel. Okay, so where this channel is there on the Telegram app, and also do not forget to subscribe for this YouTube channel, that is the Let's Crack NEET PG. In the whole month of June, I would be taking a lot of sessions for you which would help you to solve lots of questions. Chalo, let's move to our next question now. Okay, so the next question is, a patient presented with the bluish discoloration of sclera. It can be cause of any of the following except, your options are preterm neonate, L-captonuria, osteogenesis imperfecta or episcleritis. So the answer here is D, that is episcleritis. Remember, the episcleritis does not causes the blue sclera. Okay, the episcleritis usually causes the congestion of the vessels which are above the sclera. Okay, so you would see a red eye in the episcleritis and not a blue eye. When we see a blue eye is seen when there is not a total development that has taken place of sclera, or if there is a pigmentation which is there in the sclera. So pigmentation definitely can be in the L-captonuria. In the preterm neonate, there may be chances that the whole of the sclera is not perfectly formed, and in osteogenesis imperfecta, here also the chances are that the sclera, which is basically made up of the type 1 collagen, it is not fully formed. Okay, so episcleritis more a cause of the red eye, not the blue sclera. Is it clear? Okay, chalo, let's move to our next question. So next question is a OCT image. So identify the spotter here. This is a OCT image. These layers, these 9 layers which you are seeing, this is called the neurosensory retina, and the 10th layer which you can see, which is the hyper reflectile layer, this is the retinal pigment epithelium. So this layer is the RPE, and these 9 layers, they are collectively called neurosensory retina. This area is the vitreous cavity. Okay, so you are seeing a serous accumulation which is between the neurosensory retina and the RPE. Okay, what is this called? This is called a central serous retinopathy. The central serous retinopathy is more commonly seen in those patients who are the type A personality, young patients, and who have already got a exposure to steroids. So it has been seen today only in my OPD. I have seen 2 patients who have got a central serous retinopathy and they have a history of taking steroids after a COVID-19. So they can ask a question like this also. Which of the following can be the manifestation of the COVID-19? Okay, so the most common ocular manifestation of COVID-19 is conjunctivitis. And you can have other manifestations which are secondary to the inflammation or to the side effect of the drugs. The one which is so commonly seen now, that is the ocular mucormycosis. You can also see the steroid induced posterior subcapsular cataract. You can also see a steroid induced glaucoma. You can also see a steroid induced increase in the intraocular pressure. You can see a central serous retinopathy. You can see, because of the thromboembolic phenomena, you can see the vascular occlusions. Okay, so these all can be there whenever you have a patient of COVID-19. Okay, chalo, let's move to the next question. Identify this spotter. In this spotter, what you can see is in the center of the macula, you are having some layers which are deficient. So because the layers are deficient here, okay, this is basically called a macular hole. Okay, so a very common cause of macular hole is post-trauma. Okay, this is the B, that is macular hole. Chalo. Let's move to our next question. Here we are getting some spaces in the inner layers of retina. So when we get the cystic spaces in the inner layers of retina and there is increase in the retinal thickness, okay, there is increase in the retinal thickness and cystic spaces in the inner layers of retina, this is basically called a cystoid macular edema. Okay, so this is basically a cystoid macular edema. Chalo. Let's move to our next question. So next question is identify the spotter here. So what you can see in this spotter is you are seeing the fundus. In the fundus, what you are seeing is that there is a patient who is having some yellowish areas around the center of the fundus, around the macular area. And when you see in this patient, when you see the OCT picture, in the OCT picture also, what you can see is that there is a elevation of the retinal pigment epithelium. Okay, so if you can see, there is a elevation of the retinal pigment epithelium. If this is the retinal pigment epithelium, so some deposits are beneath the retinal pigment epithelium which are basically causing the elevation of RPE. Okay, so this is basically called, these yellowish spots which have distinct edges, they are called Drusens. And remember, DR goes with DR. So Drusens are seen in dry patient who are having a dry AMD. Okay, chalo. Let's move to our next question. Okay, so our next question is test used for home monitoring of the ARMD patient is modified Amsler-Dubois retinal chart, Hest chart, Maddox rod test, or Amsler grid test. So what happens in the ARMD is that the patient is having a macular degeneration, and as I told you earlier also, the macula is basically responsible for the central vision. So the patient may have difficulty in seeing the near objects. The patient may also have difficulty in understanding the shape of the objects. Okay, this is basically called a term which is called metamorphosia. Now, because these patients are old patients, it is very difficult for them to basically come again and again for the follow-up. So what we do to them is we basically give them a chart, and if they have any significant change, how they read this chart, they come back to us for the checkup. So you get a chart like this. In the chart you can see there is a square and then there are some smaller squares. What we tell the patient is to see the basically the shape of the squares, the type of the squares and the number of the squares. If this basically you get a scotoma, so some area which you are not able to appreciate. Okay, you say that, sir, I am not able to see the squares in the center of the big square or in the periphery. So this means there is some new lesion which has developed in the patient, and that can be a progression of the disease. So whenever he says that there is a change in how he basically see this chart, then he had to report back to his retina specialist for the treatment. This chart is called Amsler grid chart. Okay, now do not confuse a Amsler grid chart with another type of chart which is called Amsler Dubois retinal chart. Okay, this is called a Amsler Dubois retinal chart. What happens in a Amsler Dubois retinal chart? It is basically used for the residents and the fellow ophthalmologist. Whenever you go to a ward, let's say you go to an ophthalmology ward and you have seen a patient who is having a retinal detachment, and your professor has to come for the round. Before he comes for the round or before he goes for the OT, you have to tell the patient, you have to tell the examiner where is the retinal detachment. So you basically make it with blue color. Okay, so there is a color coding, blue color. So blue color means that this is the area of the detached retina. If you have hemorrhages there, you would basically make it with the red color. Okay. If you have neovascularization, you would make it with the fronds. Okay. So the neovascularization is basically put like fronds. So in this way, you can have all the lesions which are depicted in a chart. Okay. So this is a chart where the lesions are depicted. It is also called Amsler chart, but the full name is Amsler Dubois retinal chart. Okay, so remember that is a grid and that is a Amsler Dubois retinal chart. Both of them are totally different. Do not confuse a Amsler Dubois retinal chart with a Amsler Dubois grid chart. With this, I come to my next option, that is the Hest chart. What the Hest chart does is, Hest chart tells you about the various positions or the various actions of the various extraocular muscles. If you can see in this image, there are the actions of the extraocular muscles are seen. What we are seeing here is that only the lateral rectus is working, as well as a bit of the downward movement can be there. In the right eye, all the actions, the black arrows which you can see, all these black arrows are basically pointing that all the actions are normal. So basically this Hest chart, how it helps us? It helps us to tell you to diagnose the nerve palsies. So it can tell us about the diagnosis of nerve palsy, and it can also tell us how much has the patient recovered from this also. So this is the basic advantage of having the Hest chart. The last option is the OCT. We have basically discussed the OCT pictures. In this slide, I am basically making all of them in one slide so that you can understand the various OCT images. What is the basic function of OCT? OCT can tell us about the structure and the pathology in the retinal layers. Okay, it is a non-invasive mechanism, unlike the Fluorescein and Geography. The first one which you can see, I told you there is a serous collection of fluid. beneath the neurosensory retina and above the retinal pigment epithelium. This is called central serous retinopathy. Then the next one, which you can see that the layers of the retina are absent in the center of macula. This is called macular hole. Then you can see the RPE is elevated. The retinal pigment epithelium ये elevate होती है. This is called ARMD. Then what you can see is the cystic spaces in the center of the retina. These cystic spaces in the center of the retina, they are called cystoid macular edema. Okay, so that is the role of the various OCTs and the various types of OCTs seen in different disease. Now we come to our next question, which is on uveitis. So question is not a sign of anterior uveitis. Your options are circumcorneal congestion, flare, hypopyon, relative afferent pupillary defect. Try to answer. So the answer here is D, that is relative afferent pupillary defect. Now relative afferent pupillary defect, this is basically seen in the optic nerve head disorders. Okay, they are not seen in anterior uveitis, they are seen in the optic nerve head disorders. Circumcorneal congestion, it can be seen in your episcleritis, it can be seen in your scleritis, it can be more commonly seen in your uveitis, keratitis, okay, as well as corneal ulcers. So it is seen in keratitis and uveitis. Okay, it can also be seen in the some patients who are having a acute congestive glaucoma as well. Flare, what is flare? In the anterior chamber, in the aqueous humor, if you are seeing the proteinaceous deposits, they are basically called flare. Then we have hypopyon. Hypopyon is pus in the anterior chamber. This flare and the cells, when they get deposited in the bottom half of the anterior chamber, this is basically called a hypopyon. Remember, hypopyon is pus in the anterior chamber and hyphema is blood in the anterior chamber. Okay, do not get confused in between them. Then our next topic is snowball opacities. Snowball opacities are the signs of which of the following? Anterior uveitis, posterior uveitis, intermediate uveitis, or chorioretinitis. So remember, the snowball opacities are the signs of the inflammation of the pars plana region of ciliary body. Pars plana region of ciliary body. This is basically called intermediate uveitis. Okay, so snowball opacities are seen in the snowball opacities, and the snowflake opacities, they are seen in the patients who are having a intermediate uveitis. Okay, chalo, let's move to our next question. Next question is, Arl's triangle is seen in the patients of suffering from trachoma, anterior uveitis, optic neuritis, or intermediate uveitis. Try to answer. So what is actually a Arl's triangle? In Arl's triangle, we have the keratic precipitates which are deposited in the back of the cornea around the endothelium. Okay, so these keratic precipitates, they form a triangle. Okay, this is basically called Arl's triangle, which is basically seen in the anterior uveitis. Do not confuse it with the trachoma. In trachoma, what you see is when you evert the upper eyelid, you see a subconjunctival scarring there. This subconjunctival scarring which you see in the patients when you evert the eyelid, this is basically a sign which is seen in the trachoma. Okay, so the answer here is B. Any doubts till now? Okay, chalo, let's move to our next question. Which microorganism has predisposition to involve the macula? Try to answer. Which microorganism has predisposition to involve the macula? So remember, the organism which is basically involving the macula is the toxoplasma. If you can see in this picture, the first picture you are seeing a lot of haze in the vitreous cavity. You can just appreciate the optic nerve head, which is basically like some headlight is coming in the fog. So when you have an active stage of the toxoplasma infection, there you have a lot of inflammation in the vitreous cavity. I call it vitritis, and this particular feature is basically called headlight in the fog appearance. In the second appearance, what you can see is that basically the macula is involved. यहाँ पर हमारा मैक्यूला इन्वॉल्व होता है. मैक्यूला में हमें स्कारिंग दिख रही है और मैक्यूला में हमें ब्लैकिश स्पॉट्स दिख रहे हैं here and there. So this is basically a macular scar, which is basically called a healed stage of the toxoplasma infection. So remember, a headlight in the fog and the macular scar, they are both the features of the toxoplasma infection. Is it clear, everyone? Okay, chalo. Let's move to our next question, that is, the microaneurysms are found in which layer of the retina? The microaneurysms are the first lesions which are seen in the patients of diabetic retinopathy. So I can also say that the microaneurysms are the first sign of the diabetic retinopathy. Now these microaneurysms, they are basically seen in the inner nuclear layer of the retina. So you can basically see it and remember it with the mnemonic, that is main. So main bole to microaneurysms in the inner nuclear layer. Okay, the nerve fiber layer, you can basically have the exoplasmic stasis, and this exoplasmic stasis, what it does is it can basically make a shape of the blurring of the margins and the yellowish space. So this is basically called soft exudates. So soft exudates are seen in the nerve fiber layers, or the soft exudates are basically also called cotton wool spots, which can be seen in the diabetic retinopathy, hypertensive retinopathy or vasculitis, and they are present in the nerve fiber layer. They are the exoplasmic stasis. The retinal pigment epithelium layer, it is sometimes involved whenever there is a patient of a disease which is called a Krill's disease. What happens in the Krill's disease is there is a inflammation of the retinal pigment epithelium cells, okay, and they can basically cause a blurring of the vision of the patient. This is called a Krill's disease. Bruch membrane is involved whenever we have a ARMD, okay, whether it is a dry ARMD or whether it is a wet ARMD. In the wet ARMD, the new vessels are formed in the lowest part of the RPE and in the topmost part of the choroid, which is called the Bruch membrane. So remember, Bruch membrane is the layer of the choroid which is basically in touch with the retinal pigment epithelium. Okay. Let's move to the next question. The dye which is used in the photodynamic therapy is sodium fluorescein, ICG, lissamine green or vertiporphyrin. Try to answer. So dye that is used is called vertiporphyrin dye. Okay, what is the vertiporphyrin dye? It is a light sensitive dye. Now this light sensitive dye, this basically accumulates in the blood vessels. It accumulates in the blood vessels, and then these are the new blood vessels. They get visualized in the outside, and when we do a fundus photograph of this patient, then what we can do is we can selectively coagulate these vessels with the diode laser. Okay, this is the principle of photodynamic therapy. It is used in a type of ARMD which is called subfoveal ARMD. What is the meaning of subfoveal ARMD? The subfoveal ARMD means that, let's say this is the macula. This is the center of the fovea. Just beneath the center of the fovea, we have the new vessels. In this condition, I can basically use a photodynamic therapy where I use a light sensitive dye which is called vertiporphyrin, and I coagulate these new vessels with the help of diode laser. Is it clear? Okay, chalo, let's move to our next question. So next question comes to the radiation effects on the retina. So the question is, most radio resistant layer of the retina is, your options are retinal pigment epithelium, ganglion cell layer, photoreceptor layer, or the inner nuclear layer. Try to answer. So if they ask the most radiosensitive part of the eye, the most radiosensitive part of the eye is the lens. If they ask most radiosensitive part of the retina, the most radiosensitive part of the retina is the photoreceptors, rods and cones. The most radio-resistant part of the retina is the ganglion cell layer. And after the ganglion cell layer, which is the next most radio-resistant part of the retina, that is the retinal pigment epithelium. Okay, so answer here is B followed by A. Okay, chalo, let's move to our next question. Next question is, candle wax drippings are characteristically seen in which of the following disease? Your options are tuberculosis, syphilis, eels, and sarcoidosis. Now, what is the candle wax drippings? This is your eyeball, these are the vessels, and around the vessels what you see is the exudates are releasing like this. Okay, so जैसे कि मोमबत्ती के चारों तरफ, you have seen a candle, around the candle when the wax melts, it pours down from the sides or the edges of the candle. This is called the candle wax dippings. It is basically a characteristic of the patient who is suffering from sarcoidosis. Okay, chalo. Let's move to our next question. Which of the following is not a risk factor for diabetic retinopathy? Your options are renal disease, hyperlipidemia, hypertension, or glaucoma. Try to answer. Not a risk factor for diabetic retinopathy. So the answer here is D, that is glaucoma. The most important risk factor for diabetic retinopathy is the duration of diabetes. Okay, so duration, let's say a patient is having a 5 years for the diagnosis of type 2 diabetes, or 10 years after the type 2 diabetes. This is the most important risk factor. After the duration, the next most important risk factor is the glycemic control. How well the patient is controlling his diabetes. The other risk factors are the renal diseases, the hyperlipidemia, hypertension, and even pregnancy. Now remember, glaucoma is not a risk factor for diabetic retinopathy. Okay, chalo. Let's move to our next question. Next question is, Ocryplasmin is the newer drug used in which of the following? retinal break, vitreomacular adhesion, submacular bleed, diabetic macular bleed. Try to answer. So what happens sometime is, this is your retina, and sometimes fibrotic strands are attached to the retina. Lots of fibrotic strands are attached to the retina. These fibrotic strands which are attached to the superficial layers of the retina, if we basically do a vitrectomy, and during the vitrectomy they put a lot of traction, this can basically injure the blood vessels, or it can injure the retinal layers. So to avoid this and do a chemical vitrectomy, we can put a very important agent inside the vitreous cavity which can cause dissolving of this fibrotic strands. This is called tissue plasminogen activator with Ocryplasmin. So it has been seen in the old patients who are having a tractional retinal detachment, a diabetic TRD and proliferative diabetic retinopathy, where we want the tractional retinal detachment to basically get resolved. There you can use the Ocryplasmin. Okay, so it basically helps in the fibrotic strands which are attached around the macula, around the retina. Okay, vitreomacular adhesion. So the answer here is B. Is it clear, everyone? Okay, so as before I basically go to my next question, I would be just telling you another feature of the Unacademy Learning app. There are 4 courses which are starting in the Unacademy Learning app. I just want to tell you that these are the MBBS Foundation Professional Year 2 batch, the MBBS Foundation Professional Year 3 batch, which have the content classes, which have the clinical integrated dual educator classes, answer writing guidance sessions, test and discussion integrated to the batch, separate doubt classification sessions at regular intervals, live interactive sessions and the recorded sessions, and you can basically take the PDF notes. The objective is this MBBS Foundation batches to help third year MBBS students ace with both the university as well as the next exam, coverage of the in-depth coverage of all the chapters, 6 monthly, every alternate day 2 sessions would be there, and the timings of the session would be from 6 p.m. to 8 p.m. and 8:30 p.m. to 10:30 p.m. And this session has already started from the 19th of May 2021. You can also go with the FMG test and analysis batch and the target next 2022 batch. There is another session which I have started. This is called the Season 1 NEET PG 2021 Images Revision batch, where all the top educators are telling you about the important images that can be basically asked. So you can basically enroll for any of these batch courses, whether you want a professional year 2 batch, professional year 3 batch, FMG test and analysis batch, target next 2022 batch. The very important thing is you go for the plus subscription. And if you want to go for a plus subscription, you have a limited time offer. The 3-year subscription comes at a never believable price, which is around 58,500. And as you go down, you can enroll for a 2-year batch, you can enroll for a 18-month batch, and you can enroll for a 12-month batch. You get it at the various discounted prices. And remember, the code which you can use here is the OPHTHAL10. Okay, and if you are going for the 3-month subscription, you would get 1 month subscription free of cost. If you are going for the 1-year subscription, you would get a 2-month subscription off in these courses. Okay, chalo, let's move to our next question. Any doubts in any of the question till now? Okay, chalo, let's move to the next question. Okay, so next question is a fluorescein angiography image. So remember, whenever you are given a fluorescein angiography image, you would see the fluorescein dye, which is the whitish fluorescein dye, which looks like a whitish dye which is filling the retina. Here in this case, what you can see is that lots of patches, lots of white patches you can see around the retina. These white pouches are basically the microaneurysms. In the microaneurysms, these secular outpouchings, there is a collection of the sodium fluorescein dye. So as you can see, a lot of microaneurysms all around the macula, all around the fundus. This is basically a patient of non-proliferative diabetic retinopathy. Okay, the patient is suffering from NPDR. Okay, then this is the next F image. In this F image, what you can see is that the patient is having the leakage of dye, which is in shape of a flower petal around the macula. Okay, so this flower petal appearance, this is characteristic of the patient suffering from cystoid macular edema. Okay, chalo. Then we have this picture of the choroidal neovascular membrane where you are seeing the leakage and the pooling of dye which is around the macula. Okay, this is the choroidal neovascular membrane. I also call it wet ARMD. Okay, chalo. Let's move to the next question. The next question is, which of the following is the VEGF trap that is used for wet ARMD? Your options are Ocryplasmin, ranibizumab, aflibercept or ozurdex. Try to answer. So the VEGF trap, which basically inhibits all the type of VEGF. Okay, VEGF A, VEGF B, VEGF C, and also it inhibits the placental growth factor. This is seen to be more effective as compared to a normal ranibizumab or bevacizumab. This is called VEGF trap, also comes by the trade name of Eylea. Okay, and the answer here is C, that is aflibercept. So aflibercept is basically the VEGF trap which can be asked in the question. It is basically used in the wet ARMD as well as in the macular edema. Okay, chalo. Let's move to the next question, which is basically matching the retinal and macular dystrophies. Mizuo phenomena, it is seen in the Stargardts, oculodigital syndrome, Leber congenital amaurosis, ornithine transaminase deficiency seen in Oguchis, and Oguchi disease has the punched out lesions. Which of the following is the true match? So remember, Mizuo phenomena. What is the Mizuo phenomena? The patient can basically see good in the night, but patient has difficulty to see in the bright light. When you see the fundus in the bright light, it is more of the greenish in color. When the patient goes to the dark, after 2 hours, the fundus goes back to its normal orangish color. This is called a Mizuo phenomena. Remember, the Mizuo phenomena is seen in the Oguchi's disease, not in the Stargardt's disease. It is the Oguchi's disease. Oculodigital syndrome, it is basically seen in the Leber congenital amaurosis. This is absolutely correct statement. It is the most common retinal dystrophy which is seen in the infants. What the child does is he rubs the eyes very vigorously. He is not able to see clearly, so he rubs the eyes very vigorously, and due to the rubbing of the eyes, what happens in these patients is that these patients get a type of inophthalmos. This is called Leber congenital amaurosis. The patient having a oculodigital syndrome. So with the digits, the patient is rubbing the eyes. Okay, this is called oculodigital syndrome. So B is the correct answer here. Remember, the ornithine transaminase deficiency, it does not happen in the Oguchi disease. It is basically happening in the gyrate atrophy. Okay, and these gyrate atrophy are having the punched out lesions. Okay, so option C and option D, they are also wrong. Okay, chalo, let's move to our next question. Not a sign of Fuchs heterochromic iridocyclitis. Your options are posterior synechias, seen in young adults, develop posterior subcapsular cataract, or Emsler sign. Try to answer. So answer here is A, that is posterior synechia. Remember, the Fuchs heterochromic iridocyclitis, it is a very mild form of uveitis. In this mild form of uveitis, you do not get a posterior synechias. It is seen in usually young adults. These young adults may have different color of the iris. So one eye is having different color, other eye is having different color. This is called Fuchs heterochromic iridocyclitis. Very important is because these patients have mild uveitis, they do not come to know about this disease unless otherwise they develop a posterior subcapsular cataract or they develop a glaucoma. When you start doing a intraocular surgery in this case, what happens is as soon as you enter the anterior chamber, you get bleed in the anterior chamber. You get blood dispersal in the anterior chamber, and this is basically called Amsler sign. Okay, sure. Let's move to our next question. Which of the following is not an indication of immediate treatment in cases of trauma? Your options are retinal detachment, corneal perforation, optic disc edema, or hyphema. Sometimes the patient who has come with the trauma, he can basically just be followed up without treating the patient, without basically going for an operative intervention in these cases or before basically admitting the patient. So remember, the patient who is having hyphema, that is the blood in the anterior chamber, it does not basically mean any operative intervention in that case. This hyphema can settle on its own. Most of the times you give anti-inflammatory drugs like steroids and hyphema settles on its own. Some conditions where you need to basically drain that hyphema, these are high IOP, very high IOP, which is, let's say, more than 25 millimeter of mercury for more than 5 days. Or if the IOP is more than 50 millimeter for more than 2 days. Or the patient who has got an endothelial blood staining of the cornea, or the patient who is having high chance of recurrence of the bleed, like the patient is suffering from sickle cell anemia. In these cases, you need to drain the hyphema. In other cases, it would settle on its own. You do not need any active intervention. So answer here would be D. Remember, retinal detachment, corneal perforation, and optic disc edema, they are the signs of the very, very serious damage to the ocular structures, and they need immediate correction in these patients. Okay, chalo. Let's move to our next question. Next question is most common cause of delayed endophthalmitis in a pseudophakic patient after 2 years. So हमने सर्जरी कर दी, 2 साल के बाद endophthalmitis हुआ. What can be the most common cause? Remember, endophthalmitis is most commonly seen after a cataract surgery, but it is seen usually around 2 to 7 days after a cataract surgery. The most common cause in these conditions is Staphylococcus epidermidis. The Candida albicans is a cause of endophthalmitis more commonly in the endogenous endophthalmitis. Any endophthalmitis which you are seeing after a immunosuppressive condition, like in the COVID-19, you are seeing it after a patient who is suffering from HIV or a immunosuppressive patient. Bacillus cereus is the one which is you see more commonly after the perforating trauma. If the endophthalmitis is after some years, or if the patient has undergone a posterior capsular opacification and the yak capsulotomy, and the patient is getting the endophthalmitis after that, so it must be because of some bacteria which is having a low virulence. It is there inside the eye, but it has not done anything damage. As soon as you basically do a intervention, this bacteria gets basically stimulus to cause the inflammation in the vitreous cavity. So the answer here is Propionibacterium acnes. Okay, A should be the answer here. Okay, chalo, let's move to our next question. So next question is, patient came with the hypopion on second post-operative day. There was a corneal edema and on B scan there was vitreous amplitude spikes. The first line of treatment in these patients is intravenous antibiotics, vitrectomy, wait and watch, or intravitreal antibiotics. So as you can see in this scenario, the patient is suffering from endophthalmitis. And remember, whenever the patient is suffering from endophthalmitis, the first investigation that you would do would be the USGB scan. Okay, and here the patient has got a vitreous amplitude spikes. Okay, so normally the spikes are like this. So the spike is for lens and the sclera. If you have the vitreous opacities, they can also put a mild and moderate amplitude spikes. They are characteristic of the vitreous hemorrhage or endophthalmitis. So the first thing is the patient is suffering from endophthalmitis. The second thing is, what is the first treatment that you do? After the empirical treatment that you give, like a topical antibiotics, cycloplegics, and the anti-inflammatory, the second thing that you do is put the intravitreal antibiotics inside the vitreous cavity. Very, very important is you put the intravitreal antibiotics in the vitreous cavity. These are called the intravitreal injections. Okay, so the first line of treatment in the patients of endophthalmitis is intravitreal antibiotics. Okay, chalo, let's move to our next question. Which of the following is not a feature of sympathetic ophthalmitis? Your options are Dahlen-Fuchs nodules, decrease in near vision, snowball opacities, or retrolental flare. Remember, the sympathetic ophthalmitis, it is a very, very important granulomatous pan-uveitis which can happen in the eye which has not got a perforating trauma. So if the eye has got a perforating trauma and the trauma is near the ciliary body, what can happen in this patient is there can be a hypersensitivity reaction, and this hypersensitivity reaction goes to the other eye, and the uninvolved eye also starts behaving like a panuveitis. In the choroid, you can see some yellowish nodules which are called Dahlen-Fuchs nodules. These patients would have in the other eye decrease in the ciliary body function. So the patient would have a decreased near vision, and there may be cells and the RP cells beneath or below the lens, which is called retrolental flare. Okay, so these all are the signs of the sympathetic ophthalmitis. Remember, as I told you when I started the session, snowball opacities are not the sign of sympathetic ophthalmitis. The snowball opacities are the sign of intermediate uveitis. Okay, they are the signs of intermediate uveitis. Chalo. Let's move to our next question. The next question is choroidal neovascular membrane, which is characteristic of wet ARMD, originate in which layer of the retina? Outer plexiform, retinal nerve fiber layer, Bruch membrane, and inner nuclear layer. Now, as the name suggests, what is happening is we have two types of ARMD. One is a dry ARMD, which is the lipofuscin deposits. The other one, which is less common but more severe, is when the neovascularization starts beneath the RP in the layer of the choroid, which is called Bruch membrane. So this neovascularization, this grows beneath the Bruch membrane. It basically exudates, and these exudates and the inflammatory mediators, they can form a membrane over the RP and around the choroid. This is called choroidal neovascular membrane. So the answer is C here. Okay. Chalo. Let's move to our next question. Wrong statement regarding the gyrate atrophy. Your options are its deficiency of ornithine aminotransferase. B. It has the autosomal recessive inheritance pattern. C. Mid-peripheral chorioretinal punched out lesions are seen. Treatment is arginine rich diet. So what is happening in the gyrate atrophy is, it is a type of retinal atrophy or a retinal dystrophy where the patient is having a deficiency of ornithine aminotransferase. Now most of the retinal dystrophies, they are the autosomal recessive inheritance pattern. What happens in this retinal dystrophy is you are having the punched out lesions around the mid-peripheral retina. Okay, these punched out lesions around the mid-peripheral retina, what they are doing is they are basically causing the patient to have a decreased night vision and poor quality of vision. Okay, and what you do is, because this is a ornithine aminoaspirase transferase deficiency, you basically give a arginine free diet in these patients. Okay, so the answer is D here. You do not give a arginine rich diet, you give a arginine free diet in these patients. Is it clear? Okay, chalo, let's move to the next question. The next question is, which of the following is not used in the retinal photocoagulation? Remember, the retinal photocoagulation is basically done in the patients who are having a high risk proliferative diabetic retinopathy. So in this high risk proliferative diabetic retinopathy, the basic aim of the treatment is that we basically destroy those cells which are producing the VEGF. So हमें VEGF producing cells को destroy करना है, and how we can basically cause the damage to the VEGF producing cells? We basically use lasers to destroy them, to coagulate them. So the type of laser that we use in the retinal photocoagulation is called photocoagulative laser. Because we are using a photocoagulative laser, so double frequency Nd:YAG, argon laser and xenon arc laser all can be used. A femto laser is basically used for the cataract surgery, for the LASIK surgeries, and for the intracorneal ring segments. It is not used for the retinal photocoagulation or pan-retinal photocoagulation. Okay, chalo. Let's move to our next question. Which of the following foreign body cannot be observed as such in the retinal coats and need to be removed? So this means the question is asking you which of the following is the most retinal toxic foreign body to the eyeball. So remember, nickel, chromium and aluminium, they are very inert foreign bodies. If they are basically located around the macula, and the chances are that during the removal of these foreign body, you can basically damage the posterior pole of the retina. Sometimes we take a decision and we basically tell the patient, let the foreign body be there, because you are a one-eyed patient, because there is a high risk of losing the vision. So what you do is, you do not do anything, you just tell the patient to have a normal retinal checkup every 6 months. And also in these cases, you tell the patient to take care of the toxicity of the retina. So we do a serial ERG in these cases, serial erectoretinogram, whenever we have a retained intraocular foreign body. But remember, a patient who is having a copper or a patient who is having a iron foreign body, these patients are having a very high toxicity to the retina because of these foreign bodies, and they have to be removed from the eyeball. Okay, so the answer here is D. Let's move to our next question. So next question is, which of the following investigation is contraindicated in metallic foreign body? Your options are CT scan, ERG, VR or MRI. So remember, the investigation which is contraindicated in metallic foreign body is your MRI. If they ask what is the investigation of choice, so the investigation of choice is CT scan. The ERG is basically used in those cases we have retained intraocular foreign body to see the retinal toxicity. Okay, so let's move to our next question. So next question is regarding the sidrosis bulbi. So the question is, which of the following is not true regarding the sidrosis bulbi? Your options are rust colored cornea, dilated and non-reactive pupil, Orange deposits in the lens epithelium, intraocular toxicity of the copper. Try to answer. So the answer here is D. Remember, the sidrosis bulbi, it is not the intraocular toxicity of the copper, it is the intraocular toxicity of the iron. Okay, in these conditions you can have a rust colored cornea, you can have a dilated and non-reactive pupil, you can have a orange deposits in the lens epithelium. Okay, and there is a basically a retinal degeneration in these cases. Remember, iron is one of the most toxic foreign body to the retina. Okay, then we have the next question, not considered as the rings of trauma. So rings of trauma, what is the meaning of rings of trauma? Rings of trauma means that those are the obvious signs of blunt trauma. These are the obvious signs of the blunt trauma. Okay, so your options are sphincter tear, angle recession, corneal perforation or retinal dialysis. So from the options itself we can understand that the corneal perforation is not the sign of blunt trauma, it is a sign of perforated trauma. So the answer here is C. So what are the meaning of rings of trauma? Rings of trauma का मतलब ये है कि there are some of the signs inside the eye which may not be visible through the naked eye, but when you do a specific investigation, maybe after 6 months, 1 year or 2 years or 5 years after the trauma, they can tell that the patient has got a significant blunt injury to the eyeball. So कहने का मतलब ये है कि हो सकता है कि ट्रॉमा पेशेंट को कई साल पहले हुआ हो, कई महीने बाद हुआ हो, लेकिन पेशेंट को पता नहीं चला है कि उस ट्रॉमा ने आंख को डैमेज कर दिया। जब हमने 3-4 साल बाद उसको इन्वेस्टिगेट किया तो इन साइन से हमें दिखाई दे सकता है और हम इस निष्कर्ष पे पहुंच सकते हैं कि पेशेंट को एक ट्रॉमा हुआ था जिस ट्रॉमा ने आंख की रोशनी को परमानेंटली डिक्रीज कर दिया या फिर आंख की रोशनी को आगे चल के डिक्रीज कर सकता है। These are called rings of trauma. What are the various rings of trauma? The first one is in the central iris there can be a sphincter tear. Sphincter tear का क्या meaning है? What you would be having is that it would be having the damage to the sphincter of the pupil and you may be having a dilated pupil. Around the peripheral iris there can be a disinsertion of the iris root which is called iridodylisis. Around the ciliary body there can be the separation of the longitudinal and the circular muscles of the ciliary body. This basically in the longer term can cause a glaucoma. This is called angle recession. When the ciliary body separates from the scleral spur, this is called iridocyclitis. If there is a tear in the trabecular meshwork, this is called trabecular meshwork tear. If there is a loss to the zonules or injury to the zonules, there can be lens subluxation. And if there is a disinsertion of the retina from its origin, that is called the ora serrata, this is called retinal dialysis. So sphincter tear, iridodylisis, angle recession, cyclodialysis, trabecular meshwork tear, lens subluxation and retinal dialysis, they are all signs of the rings of the trauma. Okay, Chalo, let's move to our next question. Identify the following condition. What you can see, this is a type of rings of trauma. So if you can see, the iris has disinserted from its root. This is basically a D-shaped pupil. Okay, this is a D-shaped pupil. This is basically called a iridodylisis. Okay, Chalo. Let's move to the next question. Next question is not true regarding the ocular ischemic syndrome. Your options are microaneurysm, neovascularization and dilated veins are seen, amaurosis fugax seen more commonly in females. So remember, ocular ischemic syndrome or any type of these cardiovascular events, it is more common in males as compared to females. Okay, so the answer here is D. What is the ocular ischemic syndrome? It is basically a vaso-occlusive pathology. Okay, what does I mean is that the patient is having the ophthalmic artery which is going and supplying the blood to the eyeball, it is basically getting occluded. Okay? And this occlusion basically causes the intraocular pressure to increase. How the intraocular pressure increase? Because there is a neovascularization of the eye. The neovascularization of the iris basically causes the neovascular glaucoma, and this neovascular glaucoma can cause acute rise of IOP and sudden decrease in the vision. In the eyeball, in the retina, you can see the picture like a diabetic retinopathy. You may see some microaneurysms, you can see some dot and blot hemorrhages. Very important in these patients is sometimes the patient says that before the vision is gone, I had recurrent attacks where I got the loss of vision and then it improved itself. So patient ये बोलेगा कि मेरी रोशनी चली जाती थी और थोड़े दिनों बाद, थोड़े seconds के बाद दोबारा आ जाती थी. This phenomena is called amaurosis fugax. So remember, amaurosis fugax and all the signs of diabetic retinopathy like microaneurysm, dot and blot hemorrhages, they all can be seen in the ocular ischemic syndrome. They are seen in more commonly in males and females, and to diagnose the carotid artery blockage, you need a carotid Doppler. Okay, you need a carotid Doppler in these cases. Okay, chalo. Let's move to our next question. Next question is, Pascal is used for which of the following? Your options are angiography, laser photocoagulation, RF NFL thickness, or ganglion cell layer. Try to answer. So Pascal is called pattern scanned laser. It is basically used for a pan-retinal photocoagulation. What this is having is, it is having the prefixed spots. If you can see that there are prefixed spots here. Okay, so एक ही basically hit में आप 10 से 12 spots एक साथ डाल सकते हो. So the rapid photocoagulation can be done in these patients. This is called Pascal photocoagulation. Okay, chalo. Let's move to our next question. Next question is, not a manifestation of syphilis. Your options are salt and pepper retinopathy with extensive chorioretinal scarring, interstitial keratitis, salmon patch, or Roth spots. Try to answer. So syphilis can have variety of ocular manifestations. The first is salt and pepper retinopathy. Remember, salt and pepper retinopathy can also be seen in congenital rubella syndrome. These patients may also have the inflammation of the corneal stroma, but the epithelium remains normal. This is called interstitial keratitis. Sometimes what happens is, around the fundus you can have some isolated large hemorrhages. These isolated large hemorrhages, these are called salmon patch. The salmon patch can be seen in the patients of syphilis. It can also be seen in some other conditions also where there is a vasculopathy. Remember, Roth spots are not seen in the syphilis. Roth spots are basically seen in the infective endocarditis. So what happens in the Roth spots? You have hemorrhages, and in between the hemorrhages, in the center of the hemorrhages, you may be having some yellowish or pale colored centers, which is because of the immune complexes, fibrin or other cellular material. Okay, these are seen in the infective endocarditis like subacute bacterial endocarditis. They can also be seen in the under conditions like leukemia. Okay, chalo, let's move to our next question. The next question is, not most common ocular manifestation of ocular tuberculosis. Your options are scleritis, anterior uveitis, optic neuritis, or episcleritis. So the most common manifestation of ocular tuberculosis is anterior uveitis. Now this tuberculosis can have variety of ocular manifestations. Most common, the ocular infection of the tuberculosis is secondary to any other pathology inside the body. The patient may be having a lung tuberculosis, the patient may be having a lymph node tuberculosis, which has now gone into the eyeball, most commonly in the vascular areas of the eyeball. Okay, the most common manifestation is the anterior uveitis. Less common forms of the manifestation are your intermediate and the posterior uveitis. Sometimes scleritis, conjunctival granulomas, eyelid granulomas can also form. These patients may be having a flectanular keratoconjunctivitis also, as well as they can have the coin-shaped lesions around the retina as well. But if they ask the most common ocular manifestation, the answer is anterior uveitis. Let's move to the next question. Not a cause of panuveitis. Okay, so panuveitis is, as I told you, when all the layers of the uvea, okay, ciliary body, your choroid, as well as your anterior part of the ciliary body, that is the iris and the your ciliary body, and all the parts of your uvea are involved. Okay, this is called panuveitis, and remember, the most common cause of the panuveitis is still the tuberculosis. Behçet's disease, sarcoidosis, and sympathetic ophthalmitis, they all can cause the inflammation of all the layers of uvea. Syphilis usually does not cause a panuveitis, and this was a previous year question, so answer here is B. Okay, chalo. Let's move to our next question. A patient with complaints of photophobia came to the IOPD. On examination, there are posterior synechias and keratic precipitates. Which of the following is the drug of choice for the patient? Your options are steroids, pilocarpine, atropine, or temolet. So remember, the patient is suffering from uveitis, and whenever we have a uveitis, the drug of choice in these cases is always a steroid. Remember, whenever there is an anterior uveitis, you give topical steroids. If there is an intermediate uveitis, you can give steroids near the pars plana. We call it posterior subtenon steroids. And if there is a posterior uveitis, we can give the oral steroids there. Remember, atropine is a very useful adjunct, but it is not the drug of choice. Why atropine is not the drug of choice? Because atropine basically causes the dilation of the iris. It basically relieves the patient from the posterior synechia. It does not basically hinder or basically prevent the pathogenesis of the uveitis, that is inflammation. To decrease the inflammation, we always need steroids. So the drug of choice in these cases is always a steroids. Okay, chalo, let's move to our next question, that is regarding the TAS, that is toxic anterior segment syndrome. So your question is not true regarding the toxic anterior segment syndrome. Your options are: can mimic endophthalmitis in presentation, hypersensitive reaction to the chemical injury chemicals used in intraocular surgery is there, TAS responds to the corticosteroids very well in contrast to the endophthalmitis, vitreous exudates are seen on the USG-B scan. So remember, not true regarding the TAS, toxic anterior segment syndrome. The thing which is not true is the vitreous exudates. Remember, the vitreous exudates are seen in endophthalmitis and not in the TAS. Okay, what is there in the TAS? The TAS basically have the anterior segment. As the name suggests, the anterior segment inflammation is there. There can be a corneal edema, there can be a limbus to limbus edema, but there is no patient who is having a vitreous exudates. Vitreous exudates are seen in the USG-B scan. Another way of differentiating a toxic anterior segment syndrome as compared to the endophthalmitis is toxic anterior segment syndrome, which is basically because of the inflammation of the anterior segment. It responds very well to the steroids. Remember, endophthalmitis patients, you do not use steroids. In the patients of toxic anterior segment syndrome, you can use the steroids. Okay, chalo. Then we have this question, which is identify the sample seen here shown here. This patient is having a persistent hyperplastic primary vitreous, retinoblastoma, coloboma or uveal melanoma. So if you can see, there is a strand which is going from the posterior part of the lens to the optic nerve. Okay, so this is basically a primary hyaloid vessel. Okay, so if this basically still remains in the adult life and it is hyperplastic, this is called persistent hyperplastic primary vitreous. Okay, PHPV. Sometimes PHPV can also present with the leukoporia. Okay, so with this I end the session. Thank you very much for attending the session. Hope you have basically revised almost all the topics. Tomorrow we would be coming with another very important session, where I would discuss all the important MCQs in the glaucoma. Okay, so with this I end my session, and before I end my session I would be telling you that students can basically enroll for the Unacademy Plus program with my code OPHTHAL10, and you can basically use the OPHTHAL10 code in any of the package that you want. You want a 6-month package, you want a 1-year package, you want a 3-year package, you can use the code as you go for the higher packages. Okay, so if you can see, if you go for a 3-year package, you would get it only at 1,250 per month. Okay, this is for the plus subscription. If you go for a 3-month subscription, you have to basically have a 15,200 as the fees there, so it is around 4,000 rupees per month. So as you go for the higher subscription for more number of months, your per month price is basically decreasing. You can also go with the Iconic subscription. In the Iconic subscription, the options that you are having is 1-year subscription, 1.5-year subscription, 2-year subscription or 3-year subscription. What you would get is, here also you can use the code OPHTHAL10 and get a 10% discount there. Okay, download the Unacademy Learning app from the iOS Store and Play Store. There are a lot of free material there also, lot of MCQs there also, lot of batch courses going also, and if you basically go for a 3-year or a 3-month subscription, you would get a 1-month subscription free of cost and 2-month subscription free of cost on the 12-month subscription. With this I end my session. Hope you would have liked the session. Till then, good night, and do not forget to subscribe for our channel, that is the Let's Crack NEET PG channel. That is end of this session. Good night and Jai Hind.